So I'll be running you through some good video collection, right from the basics of ICL loading, ICL insertion, and some tricky situations where actually the hand maneuver and a play with the injector and the wound can actually help you save your life a lot of times. So, sound लगा दीजिए. So this is actually what loading to me is. So this sponge, I never take any metallic instrument while taking this ICL out of the bottle and putting inside the cartridge. So this is the reverse as against the IOL that we load, and be careful that the 3 holes that you see have to be in line while you are actually pushing the lens inside the eye. So what actually I mean by this is, so the standard 1.1, 2 side ports is my standard. I would put in a drop of phenocaine, no proprietary interest, put in some viscoelastic. HPMC stands, and this is very important. The incision always has to be marked. I always mark exact 3 mm because I don't want a wound assisted and a clear corneal incision. And then this is how the lens system goes in. And once we are injecting, what I am looking at is the 3 holes here. So the optic has these 3 holes, and if these 3 holes are in line, so line is like this, they are aligned, never ever you will have the ICL going upside down. Very gently you have to tap, don't be in a rush to push in, and let the lens unfold. Push in, go on top of the lens, push in some amount of viscoelastic so that you have a space between the endothelium and the lens, and gradually tuck. So tucking has to be at the junction of the plate and the optic. So never touch the optics here because this is the thinnest part and the most delicate part of the phakic lens. So tucking, the trailing could be through the main wound or the side, and then you can orient a viscoelastic wash. Just watch, this has to be avoided. The cornea never needs to be folded here. So a very gentle aspiration of the viscoelastic. Now just watch, this lens goes inside. I'm just observing how the lens is unfolding, and the lens has a tendency to go the reverse. So I just smartly go in and the manipulator and just push in, the lens goes in the right manner. So you have to observe how the leading part of the ICL goes inside the eye. Be very, very slow, be very gentle, let the lens unfold so that maximum part of the lens goes and inside opens up. Sometimes the edge can get stuck inside the wound. If you observe carefully, I was trying to forcefully push and the leading part is stuck onto the wound. So now watch how the lens will unfold. So you actually need to withdraw, reload, and don't try to push the lens inside because the lens can get torn off or you can have an upside down lens. Never overfill the anterior chamber. It should be just adequately. And this is what I want to describe here. It's in your hand, the rotation. So it could be clockwise or anti-clockwise, the injector. So you should always have a good hold and a good grip onto the injector delivery system. And then you can slowly, while pushing, you can just manipulate the lens clockwise or anti-clockwise rotation so that the lens unfolds in the correct direction. So never be in a haste, just watch. So the lens goes 1/4, but then you can't push in. Withdraw the lens, reload, and then you can re-inject the lens. Sometimes if the lens, just watch. This is not the Colamer, but this is a hydrophilic lens. some amount of extra effort has to be applied. I usually am not in a favor of hydroimplantation of these lenses, and I would always push in. Just watch carefully. The 3/4 of the lens was in, and suddenly I withdrew the injector, so the lens is stuck. So rather than pulling, you should gently push the lens, and you can easily escape from this situation, because the lens, most part of the lens is in, and the lens can. Now this is a quite interesting patient, non-dilating, around 4.5-5 millimeter pupil, and we thought of using a pupil expanding device, but unfortunately we were lucky enough to have the lens inside the eye. So you don't try to push the lens directly underneath the iris. Let the lens unfold in the anterior chamber, push in viscoelastic, let the chamber deepen up, and then you can slowly manipulate the lens inside the eye. Undue stress on the zonules can sometimes break them open, so be very, very gentle while pushing the ICL inside the eye. So be slow, because this lens can go either ways, and yes, it's in the correct plane. Now this is again, if you see, the injector has come up and it's halfway inside the wound. Better it is to withdraw the lens, reload, and then push in the lens. So you have to be gentle in these situations, because the moment you try to just watch the lens again, maybe not more than half, and then it goes, and then you can have it in the correct plane. Again, the lens has not been loaded properly, so the leading edge was caught but carefully delivered. So these are a gamut of situations which you can face. Just watch again. The lens leading haptic has been caught, and there is no point in pushing the lens. It's better to withdraw, and see the lens is caught, because it's a very, very delicate. The central part of the optic is just 50 microns. So you have to be very, very careful you don't tear the lens apart. Again, the same situation where the haptic, the leading plate has been caught, and watch how clumsily the lens opens up. So loading is a very, very essential part for a successful implantation of an ICL surgery. It should always be done under the microscope. Now this is a patient, keratoconus. We centralize the cone using Intax on the Smile Pro platform, and then we are taking the ICL inside the eye. It's a toric lens, and most of these patients, now it's not an off-label indication, but it's an indication for ICL in most of these toric patients. So right from low myopia. Now this is a very interesting case, came to us for a second opinion. The patient had an ICL surgery a few years back, but the surgeon couldn't realize that the lens was reverse. So if you see here very closely on the slit lamp, the lens, you can see it's at the concavity part on the anterior. There's the hole, so it gave us a clue that's an ICL, and there was a cataract inside the eye. This is how the picture looked like, and there was a ring sign where the lens was snugly sitting onto the natural lens. So a routine OCT, this is a patient who had a trauma post ICL, and there was a capture. So just irrigation aspiration. Be careful, the air bubbles can sometimes be disruptive, and just release and pushing this plate behind could solve the entire misery in this patient. And this was 5 years after ICL surgery that this patient had an injury. So the lens goes reverse. Don't panic, push in viscoelastic, and with the same set of forceps, you can just gently pull the lens from the same wound, reload and re-inject the lens. Sometimes you can have unexpected rotation of the ICLs. So I think that is one situation where under hydro you can actually rotate and manipulate the lens to the desired axis. So if the vault is low and the lens tends to re-rotate, then you need to exchange the lens to a one size up. So measurement of the vault is very, very essential in patients where you have repeated re-rotations. So this is one such patient who came to us after 2 years and had almost 90 degrees of rotation but could not settle, so we had to do a one size up for this patient. Sometimes if you have cataract, the lens is very simply push in viscoelastic. You can just push out the lens, you just pull it off. The IOL master gives you the same reading and the cataract can be performed in the same way as we do on the routine cataract surgery. So thank you very much. And